Bom dia a todos vocês. Eu não sei cada um de vocês, mas meu coração transborda de alegria nesse dia. Eu, na verdade, não sei nem como expressar a minha gratidão a Deus por um momento como esse, tão glorioso, em que estamos recebendo esse casal tão ilustre, o Dr. Scott Lambert, Elizabeth Lambert, pararam todas as suas atribuições, seus compromissos sociais, familiares, para estar nesta manhã aqui conosco, e eles que representam tanto para a Fundação Altino Ventura. Para aqueles que não sabem, esse casal e a sua família, durante vários anos, apoiaram e suportam o projeto de catarata congênita da Fundação Altino Ventura, colaborando para a prevenção à cegueira e reabilitação visual de muitas crianças, o apoio às suas famílias, a reintegração social. É extraordinário. A simplicidade, a generosidade, o conhecimento deles e a grandiosidade não se consegue expressar em um slide, mas, ao mesmo tempo, a gente não pode deixar de resumir o extenso currículo do Dr. Scott Lambert, que fez medicina na faculdade de Yale, nos Estados Unidos. Fez o curso de residência em oftalmologia na Universidade da Califórnia, São Francisco. Cursou o fellowship em oftalmologia pediátrica no Hospital for Sick Children, em Londres. Fez o fellowship em estrabismo no Instituto Smith-Catwell, em São Francisco, na Califórnia. Atualmente é professor da Universidade de Stanford, nos Estados Unidos. O Dr. Scott Lambert é referência mundial. Inúmeras publicações científicas, consenso, white paper, muitos estudos com o FDA, é reconhecido internacionalmente por suas contribuições nas áreas de catarata congênita, retinopatia da prematuridade e oftalmologia pediátrica em relação a outras desordens oculares. É o principal investigador do famoso estudo IATS, Infant Aphakia Treatment Study, um dos mais importantes estudos clínicos internacionais multicêntricos sobre a catarata congênita. É autor de importantes publicações científicas, livros na área de oftalmologia pediátrica. Faz muitos projetos no mundo inteiro, na África, na Ásia e em outros países. É parceiro internacional histórico da Fundação Altino Ventura no projeto de catarata congênita. Resumindo, a trajetória do Dr. Scott Lambert é marcada por muita excelência, muita qualidade em ensino, pesquisa e assistência. Assistência muito humanizada, fazendo prevenção à cegueira e reabilitação visual na população pediátrica e na questão de estrabismo de criança e de adulto. Não podíamos estar mais bem, digamos, abrilhantados nesses dias de recebendo essa visita desse casal tão querido. Elizabeth vi pessoalmente conhecer a Fundação Altino Ventura. Ontem eles puderam visitar o centro de reabilitação, visitaram também a nossa capela, em que o grupo musical Menina dos Olhos fez uma linda apresentação com Eliane Teles, a nossa musicoterapeuta, e também Keitiane Barros, com os nossos pacientes e seus familiares. Visitaram o hospital Marcelo Ventura, e hoje vamos ter o privilégio de tê-lo conosco. A doutora Bruna Ventura vai operar cirurgias de catarata pediátrica, e depois ele vai estar discutindo casos clínicos muito bem organizados, e eu queria parabenizar as alunas do curso de residência médica e especialização da Fundação Altino Ventura, que organizaram Larissa, Bruna Malta, Mariana e, estou faltando uma, me ajudem aí, e Larissa Aguiar. Obrigada, e Mariana, exatamente. Ontem à noite estávamos reunidos, então vocês estão de parabéns e ficamos muito orgulhosos. Eu gostaria de, antes de convidar o professor Scott Lambert para dar a sua palestra, agradecer a parceria, Esse é um ano muito importante para a Fundação Altino Ventura, a indústria sempre nossa parceira, e aqui agradecer aos nossos patrocinadores ouros, a Cristália, representada por Tomás Martins, gerente distrital do Nordeste. Eu queria que vocês se levantassem para a gente bater palma para vocês da Cristália. Nossos queridos parceiros, sempre conosco. Muito obrigada, de coração. Obrigada, Tomás. Obrigada à AGBio, representada por Eduardo de Almeida, gerente distrital, e também Linderman Pessoa, representante da promoção médica. Vocês puderem estar aqui, levantem para a gente bater palma e agradecer a vocês. Muito obrigada, AGBio. E, nesse momento, não quero mais tomar o tempo, porque estamos ansiosos para aprender com o nosso convidado de honra, professor Scott Lambert.
It's wonderful to be here. I'm sorry that I don't speak Portuguese. Hopefully you can understand my English. It's wonderful to see such a large group here. I teach at Stanford University, and we have probably a third the number of residents and fellows that you have. It's much smaller. You have quite a large group here. It's wonderful to see you and see what, it's exciting to know what you'll be doing in your careers and the good that you'll do in Brazil because of your training that you're receiving here. So I'm going to talk today about the management of congenital cataracts, and is a topic that I've been very interested in during my career. And I've been an author or co-author in several publications relating to this recently. One that was published in Survey of Ophthalmology, and one that was published in Asia Pacific Journal of Ophthalmology. And I'll basically be discussing some of the topics presented in these review articles. Before doing so, I wanted to thank Bruna and Marcelo Ventura for their invitation here, and Liana and a wonderful introduction. This is a photograph taken of us in Boston. Probably it was in March, so I guess about 2 months ago. And in addition to Dr. Ventura and the two Dr. Venturas, there's also Lucy Barker here, who's from Moorfields, and she was one of the co-authors of this paper, and Ed Wilson, who's also a pediatric ophthalmologist in the United States. So I'm going to start by presenting some cases. And these are cases that from my practice in the last few years. So the first one is a 4-week-old infant who had persistent fetal vasculature in his left eye. The mother is a nurse, and the father is a software engineer. I live in California, where there's around Silicon Valley, so there's a lot of software engineers where I live. The parents had been to see another ophthalmologist who had given a very guarded prognosis. And so the question I have for you is, if you were to see this patient in your practice, what prognosis would you give the parents for vision in the affected eye? Do you think it would be 2200 or worse? Maybe show by the raising your hands. 2050 to 2100? Or maybe 2040 or better? Okay. Okay. So I don't know how this child is going to turn out, but I did do a lensectomy on this child when the child was 5 weeks of age. That left eye was a little bit smaller, about 1 millimeter smaller than the right eye. And the child is now 7 months of age and is wearing a contact lens on his left eye, aphakic left eye. And the pressure is normal in both eyes. He does have an intermittent exotropia of about 20 prism diopters. And the parents are patching the right eye 4 hours a day, and they feel like the child can see in the left eye quite well, but we'll have to see. Time will tell. The second patient was 1 week old when I first saw this child. He referred to me for cataract surgery. The child was product of a full-term pregnancy, and like the other child, the mother is a nurse. And this shows a photograph of the child's eye, the right eye, you can see that there's a nuclear cataract, and there's also see these blood vessels coming up from underneath, which is consistent with persistent fetal vasculature, PFV. So what age would you perform cataract surgery in this child? Again, show me by the raise of hand, would you do it 2 weeks of age? Would you wait until 5 weeks of age? Or maybe 8 weeks of age? Okay, so it seems to be number 5 weeks of age with consensus. And how would you correct this child optically after cataract surgery? Would you implant an intraocular lens? Would you do fit the child with a contact lens or glasses? Okay. And I performed cataract surgery at 5 weeks of age. I, in fact, fit a contact lens. I had an optometrist fit the child with a contact lens. And we did part-time patching of the left eye. And the child is, I just saw the child a few weeks ago in follow-up, and the child is now 6 years old. And she sees 20/30 in the affected eye, 20/25 in the other eye. She's wearing a 14-diopter silicone hydrogel contact lens on her right eye. The pressure, she's orthotropic. The pressure's a little bit higher consistently on the right eye, but still okay. No, there's no treatment for glaucoma. It's 21 versus 17. And the mother's currently patching the left eye 4 hours a day, 3 days a week. So the child has done really well. And I think it's partially because the mother is so conscientious about doing the patching and having the child wear the contact lenses, as you would expect with a mother who's a nurse. The third case was referred to me when he was 3 weeks of age. This little boy who had cataracts in both eyes. Father noticed the cataracts at 1 week of age. The mother had had a viral illness during the pregnancy. But otherwise, the pregnancy was uneventful, and there was no family history of cataracts, including a 3-year-old sister. So this shows the cataracts in both eyes. You can see they look very much like each other. And so the question is, what age would you perform cataract surgery? 2 weeks of age? 4 weeks? Or 8 weeks? It seems like 8 weeks is what people are suggesting. And how long would you wait before performing cataract surgery on the fellow eye? Would you do them on the same day? No? You wait 1 day? Michigan, show me by raising your hands. Wait 1 week? People, okay? Or 1 month? So 1 week seems to be the consensus. What laboratory test would you be most likely to determine the etiology of the cataracts in this child? Would it be torch titers? Okay. Urine reducing substances? Genetic testing using a congenital cataract panel? Or urine amino acids? So it seems like torch titer is what people think would be the best test. And how would you correct this child optically after cataract surgery? Would you use intraocular lenses? Okay. Glasses? Or contact lenses? So it seems to be the intraocular lenses are the choice here. So what I did cataract surgery in both eyes on the same day. I did lensectomies. I did not implant intraocular lenses. Because the child was only 4 weeks of age, he was admitted to the hospital, overnight observation, and he was seen by a geneticist who ordered some genetic testing. And the genetic testing came back as being positive for a pathogenic variant on the major intrinsic protein gene, MIMP gene, which can be associated with congenital cataracts. And the child is now 5 years of age, sees really well in both eyes, 20/25, is still wearing contact lenses, is now wearing a 24 diopter contact lens on the right eye, 23 diopter in the left eye, doesn't have nystagmus, he's orthotropic, intraocular pressure is normal. The only problem he's had is that he had some capsular phimosis in the left eye So it's difficult to refract him unless you dilate the pupil. But otherwise, he's seeing well and is done exceptionally well. So I want to talk about some of the principles in these cases. So first of all, the age at the time of cataract surgery is probably the most important factor in determining the visual outcome. And optimal time, this generally believed to be between 4 and 8 weeks of age for doing cataract surgery, maybe a little bit younger for unilateral cataract, and maybe a little bit older for bilateral. Delaying surgery until a child's older increases the risk of amblyopia. However, doing surgery at a really young age increases the risk of glaucoma. So we never do surgery before 4 weeks of age for that reason. We like to wait at least 4 weeks. This is a figure from a paper written by Eileen Birch that was published, I guess 30 years ago, in which she sort of looked at the visual outcome in children with unilateral congenital cataract, trying to understand what age they did the best at. And she showed that it wasn't a linear relationship. I don't know if you can see this here. This would be a linear relationship, but it was more of a bilinear relationship where it seemed like it didn't make any difference up until 6 weeks of age. And then if you delayed the surgery beyond 6 weeks of age, then there's a drop-off in the visual outcome. So the teaching is generally you want to do the surgery for unilateral congenital cataract by 6 weeks of age to get a good visual outcome. This is another paper we wrote in, I guess, 20 years ago, looking at the visual outcome related in relationship to age at surgery for children with bilateral congenital cataracts. And there is a linear relationship, but it's not quite as striking as with the unilateral congenital cataracts. But you see that as the older you get, the worse the visual outcome. But the thing that was probably most striking to us was that if you develop nystagmus, which is, you can see the little asterisk, that generally they didn't do as well. And so the idea is that you want to do the cataract surgery before the child has nystagmus, if they have bilateral cataracts. And you can see that the children who had surgery early on, many of these children saw very well, but there were a few children who even had surgery at an older age that did well. Like this child had surgery at 18 weeks of age. So it's not a perfect relationship, but there is certainly a correlation between the age of surgery and the visual outcome. This idea of doing cataract surgery in both eyes on the same day is somewhat controversial, but I think more and more is being accepted that these babies, it's quite challenging for them to get general anesthesia. So there's some advantage to doing surgery on both eyes on the same day, so you don't have to put them to sleep twice. It does, however, increase the risk of certain complications such as endophthalmitis and toxic anterior segment syndrome. Do that, so we're very careful. We use different instruments for both eyes, use different solutions. And I haven't really had a problem. And I would say most people, I think, in the United States now, if a baby has bilateral cataracts, they would do surgery on the same day for both eyes. We generally don't do intraocular lens implantation in both eyes on the same day. This is children that we're going to be leaving aphakic after doing lensectomies. So the next issue is the issue of optical correction, and it seemed like there was a lot of feeling here that intraocular lenses were a good choice for a baby. I would say that my personal preference is to leave the babies aphakic and treat them with a contact lens, even if it's bilateral. Sometimes we'll give them glasses if it's bilateral, if they have a difficult time with the contact lenses. We usually wait until a child is at least 6 months of age before we put an intraocular lens in their eye. But this is just, I realize that in many parts of the world that contact lenses are more expensive and difficult to get, and so it probably depends on your access to contact lenses. So we have 3 kinds of contact lenses we use on children. The most popular are the silicone elastomer lens, which is a lens that can be worn for 1 to 4 weeks at a time without having to clean it. It's very easy to fit, and they're very popular. The brand that's used in the United States is called Silsoft. Another choice is gas permeable contact lenses. They're daily wear contact lenses, so that parents have to be able to put it in and take it out every day. And the advantage of these gas permeable contact lenses is that they're quite easy to put in and take out of the eye, and also they're less expensive than the silicone elastomer lenses, and they can be made customized to the optical needs of an infant. The third choice, which has been available more recently, are silicone hydrogel contact lenses, and they have the same comfort as a soft lens, and they don't have as many lens deposits as the silicone elastomer lens, but they generally can only be made up to about 20 diopters. So when they have a really high power, you have to use one of these other kind of contact lenses, and as the power goes down, then you can switch to the silicone hydrogel contact lens. Intraocular lenses are not approved in the United States for patients under the age of 22. We had this workshop, as I mentioned, in Boston, in which we discussed this. And there's a few countries in the world where intraocular lenses are approved. One is being Japan. The other is in Europe. But in Brazil, they're not approved in children, and they're certainly not approved in the United States. But we're trying to change that. Right now, they're being used on an off-label basis. And I just read yesterday a paper that was written based on results of this workshop, which they're hoping to publish quite soon. And we're in the process of trying to get the Food and Drug Administration to approve this in the United States. And I think this will probably happen soon, but right now it's an off-label use. One of the difficulties of putting intraocular lens in a child's eye is their eye is growing very rapidly. You can see this here in this figure, that the child's eye goes from being maybe 17 millimeters in length at birth to being maybe 22 millimeters in axial length by the age of 1 or 2. And so there's this tremendous change in the optical correction needed. And so it's difficult to accurately predict this. And so that's one of the challenges of putting intraocular lenses in babies. Once the children are older, then there's less growth that occurs. As you can see up here, it starts to level off. And so it makes more sense to do it at an older age. So single-piece monofocal IOLs are used in most children. And generally, it's recommended that the lens be put in the bag, but in some cases, 3-piece lenses are put in the sulcus. Toric IOLs are generally reserved for children who are somewhat older, that have a large amount of astigmatism. And it's our feeling, I think generally it's a consensus around the world, that multifocal enhanced depth of field IOLs are not appropriate in young children because of this large myopic shift that's occurring. And so it really doesn't make there's no advantage of putting a multifocal lens if they're going to be -10 myope. So one of the problems with putting intraocular lenses in a child's eye is they oftentimes develop these visual axis opacities, as you can see on this slide. And by putting a lens in the capsular bag, you basically leave the capsular bag open, and so this lens material can escape from the capsular bag and migrate into the visual axis. So we did a study called the Infant Aphakia Treatment Study, in which we compared contact lens treatment versus intraocular lens treatment for infants with unilateral congenital cataracts. And we didn't find a difference in terms of the visual outcome, but there was this tremendous difference in terms of the number of adverse events that required additional surgery. And the most common adverse event was lens reproliferation to the visual axis. So in the contact lens group, it's only 4% of these patients had this complication versus 40% in the intraocular lens group. And there's also much higher incidence of pupillary membranes and chorictopia in the intraocular lens group. So when I first started off in doing pediatric ophthalmology, we would do the torch titer on every patient that came in with bilateral congenital cataracts. But there's been a shift, and I would say at this point what most people do is genetic testing, as we did with this child I presented to you. They have these panels now that you can use for genetic testing for cataracts in the United States. I assume they have them in Brazil as well. And you basically test for about 100 genes, and you can generally, we've found that we've been able to identify many mutations that cause congenital cataracts. This is from my practice, and shows that the different types of genes that are affected. So you can see the gap junction genes, a large percentage of them are affected, collagen genes, crystalline genes, DNA repair, protein turnover genes, galactose, and syndromic, different things. And in some cases, you can actually identify systemic diseases that can be treated by doing this genetic testing. And I have never actually had a torch titer come back positive in my nearly 40 years of doing pediatric ophthalmology, but you can see that maybe like half of the patients that we test genetically, we find a cause for the cataracts. Patching therapy is a very important part of the treatment of unilateral congenital cataracts. So it's important that you patch the fellow eye so that the affected eye has an opportunity to develop normal vision. And the biggest risk for vision in these eyes is amblyopia, which is what you're treating with the patching. So to illustrate this, I'll present another case. This is a case I treated many years ago, kind of early in my career when I was at Emory University. And this patient was diagnosed with nuclear cataract at birth and referred to me, and I performed a lensectomy when the child was 6 weeks of age, and the child was then fitted with a silicone elastomer contact lens, 29 diopter lens, which she wore until she was 5 years of age, and then she switched to a silicone hydrogel contact lenses at age 5. So the mother was extremely conscientious about patching, and she kept a record in her diary, about how much she had patched the child, and she gave this to me many years later. And so what we recommended in the study is that they patch the affected eye, or patch the normal eye about half the waking hours, which she did for until the child was about 13 months of age. But then she started to reduce the amount of patching. Around 14 months of age, so it was just 5 hours a day. When the child was 2.5, she reduced it to 4 hours a day. 3 hours, by age 3, she was only doing 2 hours a day of patching. And then at age 4, she started patching every other day. When the child was 5 to 7 years of age, she was patching just twice a week. And then when the child was 7 years of age, patching was discontinued. And when I left Atlanta, where I was treating her at age 11, that's Rain, I guess. She was, she could see 20/20 in both eyes. She was still aphakic in her left eye. He was wearing a plus 18 diopter contact lens. The intraocular pressure was normal. She was orthotropic. And the amazing thing is that she had normal stereopsis, 40 seconds of arc of stereopsis, which I attributed to the fact that the mother did less patching than what we had recommended. I think that less patching allowed this child to develop better binocularity than the child would have otherwise. So she recently sent me this picture of her at her college graduation. She graduated from University of Washington, and she told me she'd been wearing a gas parental contact lens in her left eye over a soft colored contact lens because the eyes were slightly different colors. And she was considering a secondary intraocular lens, but this is probably my best outcome of a patient where basically she has normal vision in her affected eye. So I think for children with a unilateral congenital cataract, it's important the surgery be done early, between 4 to 8 weeks of age. And I personally like to leave them aphakic if the parents are able to manage the contact lens. And then you patch the fellow eye, and we start out patching them half their waking hours, but then I think it's important to taper the patching starting around 1 to 2 years of age and reduce it so that the child has a chance to develop binocular vision, and then can stop the patching between the ages of 5 to 7. It's important to monitor their intraocular pressure because they have a high risk of glaucoma. For children with bilateral congenital cataracts, again, the surgery should be done early, between 4 to 8 weeks of age. And I generally perform the surgery on both eyes in the same day, using separate instruments, solutions, and medications. And then I leave the child aphakic until they're at least 6 months of age. They can wear either contact lenses or glasses, and then later on they can have intraocular lenses put in their eyes. And so I want to end by sharing with you a letter that I received from a parent. Again, I received this not too long ago, and this was a patient who I treated when I was at Emory, and I'm now at Stanford, so it was a few years ago. And the mother wrote to me and said the following. She said, "We didn't know what to expect when we brought Riley to you at a week old. We were so scared and worried that her vision would be significantly impaired. With your expertise and guidance, Riley is thriving. We are amazed at her talent each day. She completes one of her drawings. Most people don't know that she was born with cataracts. They think she just wears glasses. When they hear her story, they are blown away. Thank you doesn't seem to say enough. You give Riley her sight, and her sight is who she is. She is creative, energetic, athletic, and funny, but everyone knows Riley is an artist." And this is the mother sent me a copy of this painting that Riley had made of a sea turtle, which is, the little girl was about 10 years of age when she made this for me. But it's quite amazing that someone who had cataracts in both eyes could draw such a beautiful painting. So I want to thank, again, Venturas for inviting me. And I actually have a presentation I want to make to So this is a copy of a textbook I helped to edit recently, and I wanted to give it to you for your library. I very much appreciate the invitation being here. Thank you.